So this is a case of a patient with mature brown cataract in whom I performed femtolaser assisted cataract surgery. That was several years ago. Nowadays, I'm not sure that I would perform a flex in this case. 87-year-old male, brown cataract with EPHIS, no known pseudoexfoliation syndrome, with good endothelial cell count. The cataract looks like this one, as you see here. The mydriasis is not the best one, so not more than 6 millimeter diameter of the pupil. Anyway, the femtolaser helped me just a little bit in dividing the pieces of nucleus, and I'm performing my standard chop technique, no groove initially, so no stop chop, directly chopping, but in this case I've been helped a bit by the femtolaser. Anyway, I had extreme careful separation of these brown hard fragments, and I adjusted the parameters in order to have a safer procedure. You can watch them on the screen. During the surgery, I'm not sure that it's shown in this video, but in all the cases like this, I use Viscoat for the endothelial protection. And under it, I put simple classical methyl cellulose, 2%. But Viscoat is, I can consider to be very good for endothelial protection. And in this case, it was not a special cornea, a normal specular microscopy. In order to stabilize the iris, because it is an EPHIS eye, I decided to implant, for a better visualization of the periphery, I decided to put 4 iris hooks. And I'm using the injector, viscoelastic in the arterial chamber, viscoelastic in the cartridge, and with my left hand I want to inject more viscoelastic just to stabilize for a better anterior chamber depth and back stabilization. And while I'm pushing the OVD with the left hand, but it was pushed in the bag, look what happened. It was my first case and the only case like this. And I really didn't know what happened. I checked carefully the IOL, the cartridge, everything, the injector, the plunger, all of them looked okay. Then what happened? I didn't lose too much time to find the cause. I needed to be more concerned about what's next to happen. And there were 3 options after the anterior vitrectomy, of course, a large anterior vitrectomy. Keep the same 3 pieces IOL and fix them at the sclera. My preferred technique when I have 3 pieces IOL to fix at the sclera is glued, a Garval technique, so with scleral tunnels. Or inject myocol, constrict the pupil, and implant artisan aphakic IOL, either in front of the iris or behind the iris. I preferred to put it in front of the iris due to the age of the patient and the life expectancy, and also due to the good endothelial cell count and morphology. I think putting it anterior is, let's say, easier and anyway more controllable. You see exactly how much the quantity of the iris that you keep and catch in the haptics. So more controllable than putting it posterior, but also if I would have had a bad cornea, I would have chosen to put it posterior to the iris. Just a small suture on the incision, and that's all. Thank you.